This slide's presentation will give an overview of different basal ganglia disorders. So just as a quick review from neuroscience last year, this slide shows basal ganglia. Okay, what you see is a frontal section through the brain. If you remember, here in the middle, you have your lateral ventricles. And that's a nice landmark. And here on the right-hand side of the slide, you have what are known as the basal ganglia. The basal ganglia consists first of the caudate nucleus, which is right up next to the lateral ventricle, as well as the putamen. Putamens here, remember collectively, the caudate nucleus and the putamen are known as the striatum. You have the globus pallidus internus and externus segment, and collectively globus pallidus internus and externus with the putamen is known as the lentiform nucleus. Here underneath the thalamus you have your subthalamic nucleus. Remember, the subthalamic nucleus plays an important role in the indirect pathway. And then finally, down here, actually present in the midbrain, is the substantia nigra, or black substance. I don't know if you remember when we did the cross-section through the midbrain last year in neuroscience, we were able to see the substantia nigra present in that area. And it's actually the substantia nigra that's responsible for the production of dopamine in the system. And dopamine is going to be an important regulator of the basal ganglia system. So in general, basal ganglia play an important role in movement. Specifically, they're involved in the initiation of movement, the inhibition, as well as the modulation of movement. And in today's lecture, we're going to talk mostly about Parkinson's disease and Huntington's disease. And Parkinson's disease patients have difficulty with initiation of movement, and Huntington's disease patients have specific difficulty with inhibition of unwanted movement. So, typical signs and symptoms of all basal ganglia disorders are shown on this slide. You should specifically expect, no matter what the basal ganglia disorder, some sort of change in muscle tone, a decrease in movement coordination, decreased motor control, postural stability problems, as well as the presence of extraneous movement. Okay, all of these things should be what you would expect in patients with any kind of basal ganglia disorder. Common basal ganglia disorders that we're going to talk about in this slide's presentation are, first and foremost, Parkinson's disease, Parkinson's plus syndrome, Wilson's disease, and finally Huntington's disease. And the rest of these slides are going to cover each of these problems in turn. First, Parkinson's disease. Parkinson's disease, you should be aware, is the most common basal ganglia disorder. As I mentioned previously, it's caused by a degeneration of the dopaminergic neurons present here in the substantia nigra. Okay, nobody really knows what causes it, but it appears that there is a small percentage that is hereditary. It usually affects people that are older than 50 years old, but there can be a premature onset in a number of individuals. Most common would be Michael J. Fox. It affects 2% of all individuals 65 years of age and greater, and it appears to be more common in men than in women. Parkinson's disease has a very standard clinical presentation. If you look on the right-hand side of the slide, Parkinson's is characterized, or Parkinson's patients typically display rigidity and trembling of the head and other extremities. Very common to have a tremor. There's going to be a forward tilt of the trunk, especially in later stages of Parkinson's, which we'll see as we look at videos later on. There's a reduced arm swing, typically. There's rigidity and trembling of extremities, as well as a shuffling gait with short steps. Okay, typically Parkinson's is going to present unilaterally. That means one side's going to be affected first. It is known to be either tremor dominant, where you have tremors of the head or the extremities, or postural control dominant. Okay, so two different kinds. Over on the left-hand side of the page, you can see that the tone changes in Parkinson's are standardly cogwheel rigidity, okay, not necessarily spasticity, but here, cogwheel rigidity. Bradykinesia, which is a very distinct slowness of movement, typically takes these patients a long time to do anything. And they're going to have specific difficulty with initiation of their movement. Early on, these patients will display a masked face. That means that they're not showing any sort of emotional reaction. Okay, postural abnormalities are indicated by a flexed posture, as well as decreased equilibrium reactions. And because of these decreased equilibrium reactions, a lot of Parkinson's patients have difficulty with falls. They may or may not present with a resting tremor, and this is very different than a cerebellar disorder that's going to have an intention tremor. Parkinson's patients don't need to be moving to have the tremor. It's just always there. Commonly seen as it can be a pill rolling tremor, seen in the hand. And then finally, they have decreased trunk rotation due to the stiffness of their trunk. As far as a movement system diagnosis, if you remember way back into the fall semester, we covered different movement system diagnosis that are recommended for us to know via APTA Neuroacademy. And the movement system diagnosis for Parkinson's patients is hypokinesia. And this is due to the slowness of their initiation and execution of movement. In addition, with hypokinesia, you should be aware of the fact that a Parkinson's patient not only has difficulty or slowness in doing the movement, but they can stop at any time. And this is sometimes called freezing of gait. Okay, you can determine the movement system diagnosis of hypokinesia through a task analysis, as well as all the other movement system diagnosis that we've talked about. With postural control, as I've just mentioned, there's going to be a delayed postural adjustment. Okay, so these patients are very prone to falling. For sit to stand or stand to sit, these patients might need assistance with initiation of the movement, and they might have difficulty with initiation of gait, or they might need some sort of assistance if their gait freezes. Okay, so all of these things together would indicate hypokinesia, which is the movement system diagnosis for patients with Parkinson's. And this slide lists some common Parkinson's movement difficulties. There's going to be some typical gait changes that you'll see that are listed here on the left of the slide. So there's going to be decreased velocity or just slowness of movement, decreased stride length and foot clearance, a foot flat progression. You're going to notice a decreased arm swing, and as well as something called freezing of gait. That's where the person just stops when they're trying to walk. They're really trying to go forward, but they get stuck, and that's called freezing. There's also something that you're going to see that's called festination. And festination is nothing more than when the patient's feet are moving very rapidly, but they're standing in place. And it's really an attempt of the person to try and catch up their base of support with their center of gravity. They're not really moving anywhere, but their feet are moving very fast, and that's called festination. And in addition to festination, we also have retropulsion, and that's going to be the tendency of the person to fall backward. Okay, go ahead and pause the slides presentation and watch the video. The video itself doesn't have any sound, but there are some subtitles, and it starts out with early phase gait changes in Parkinson's disease and progresses all the way through to later stage gait changes that you'll see in this patient population. What you need to be aware of is that the Parkinson's movement difficulties are triggered by certain things. On the left-hand side of the slide, you see that freezing in gait can be triggered by sudden changes and turning in directions or pivoting, which we saw in the video. If the person is going to cross over a threshold or through a doorway, that can cause them to freeze. Approaching obstacles such as furniture, turning around to sit down, any kind of change in floor patterns. So, for example, going from a carpet to a tiled floor, or just having a different color tile to step onto can cause the person to freeze. Other things include being in a confined space or crowds or anything that causes stress or having the person try to hurry. Next, there's retropulsion, and retropulsion on the right-hand side of the slide, you can see if the person is going to try and back up to sit down, that might cause them to go backward. Reaching overhead, so for example, reaching up for something in a cabinet or a countertop, and stepping away from something, opening a door, you can imagine having that door pull open, and as you're pulling it open, you're causing that person to move backward. Or carrying items close to your body, or being suddenly jostled or approached. Parkinson's disease also has some secondary problems and complications, and those are listed on this slide. Overall, you can expect this person to have decreased muscle endurance. The more tired the person gets, the more flexed their posture is going to get. Okay, they're going to start to bend at the hips and go forward. They're also very susceptible to osteoporosis because of dietary changes, age, as well as decreased activity. In later stages of Parkinson's, you can expect contractures and deformities to happen just because of lack of mobility, as well as pressure sores. And there's also a significant respiratory compromise, especially at the later stages of Parkinson's. You should be aware that the most common cause of death for patients with Parkinson's is going to be pneumonia. In addition to the motor symptoms that we've covered, there's also some severe non-motor symptoms to be aware of with this patient population. This slide shows some of the cognitive changes that these patients have. You can see there's anxiety, depression, bradyphrenia, or decreased ability to think. Okay, they're very distractible. And they have a decreased attention. They also have difficulty with executive functioning, dual task activity, and going with executive function, the ability to organize. Other non-motor symptoms to be aware of that have nothing to do with cognition are sleep disturbances, bladder urgency and frequency, orthostatic hypotension, which is a problem not only with Parkinson's, but with some Parkinson's medication. Hyposmia is a decreased ability to smell anything. Okay, if they're not able to smell, then they might not be able to taste anything, and that might be why they don't feel like eating and their diet isn't very good. They might also complain of pain and paresthesias or numbness and tingling. Okay, as far as Parkinson's disease is concerned, there's something known as the modified Hone and Yar scale, which is shown on this slide. There's stages 1 through 5, as listed on the left-hand side of the slide. And stage 1 is indicative of early stage Parkinson's. If you remember from the video, the early stage patients that you were reviewing had only one-sided involvement. That's indicative of stage 1. As you progress through this disease, stage 1.5 is characterized by unilateral as well as some axial or trunk involvement. Stage 2 is going to be bilateral involvement, but no balance issues. And stage 2.5 is going to be bilateral disease with recovery on the pull test.
Retropulsion. The patient stands with feet slightly apart. Explain you are going to pull them gently at the hip and that you want them to try and keep their balance, taking a step if necessary. If the patient takes 3 or more steps back or falls without taking a step, then the test is positive. This can show central involvement, such as basal ganglia disorders.
Okay, so that was an example of the pull test. It's indicative of retropulsion. Stage 3 is going to be a moderate bilateral disease with some postural instability. But in stage 3, the person is still physically independent. Okay, they don't need any help with anything. And stage 4 is going to be severe disability, but they're still able to walk or stand unassisted. The unassisted is going to mean without the help of another person. Okay, they might need the help of an assistive device, but they're able to walk without the help of another person. Okay, in stage 5, the last stage of Parkinson's is where the patient is wheelchair bound or bedridden unless they have some help from another individual. In addition to Parkinson's, you need to be aware of some Parkinson plus syndromes. The first one listed on this slide is something known as progressive supranuclear palsy. It's similar to Parkinson's disease, but there's more of a cognitive impairment, and the progression is much more rapid. And it's usually identified on the basis that it doesn't respond to a supplemental dopamine replacement. Okay, if you remember, Parkinson's is lack of dopamine. Progressive supranuclear palsy doesn't respond to supplemental dopamine. The other Parkinson plus syndrome is known as multiple system atrophy. It involves cortical, basal ganglia, and cerebellar. Okay, it's characterized by frontal lobe involvement as well as autonomic dysfunction. That person has very poor blood pressure control. And in addition, it does not respond to L-DOPA. So just a little bit of difference from straight up Parkinson's or these Parkinson plus syndromes that you might come across in your future. In addition to the Parkinson's plus, there's also something known as Wilson's disease. This is also known as hepatolenticular degeneration. And what happens here is that the person isn't able to metabolize copper properly. Copper builds up in both their liver and their basal ganglia. If it's identified early on, the patient can function without restrictions. In addition, Wilson's disease, as you can see on the right-hand side of the slide, is characterized by some neurological symptoms such as tremors, emotional problems, and difficulty with handwriting goes with the tremors. They might have difficulty talking, and they may appear like they have symptoms of Parkinson's disease. Next is going to be Huntington's disease. Huntington's disease is a little bit different in that it is a progressive disorder, and it does involve the basal ganglia, but in this case it's going to be basal ganglia hyperactivity. Okay, where Parkinson's disease is a paucity of movement and slowness of movement, Huntington's disease is excessive movement. Okay, the disorder itself is an inherited autosomal dominant trait. That means if your parents have it, you have the 50% chance of getting it. And it can be identified with genetic testing. Okay, the symptoms usually appear between the ages of 30 and 50 years old. That's when they start. Lifespan is significantly reduced, probably around 19 years after diagnosis would be the average lifespan. And the coronal section that you see at the top of the slide on the right-hand side shows the enlargement of the lateral ventricles. If you remember the very first slide that I showed when I talked about what the basal ganglia were, the caudate nucleus resides very closely with these lateral ventricles, and the destruction of the caudate appears to have the lateral ventricles enlarged. Okay, there's also a video here. Daniel, my brother, has a patient with Huntington's disease. If you really want the later stage of the disease for Huntington's, this is also something that we watched in neuroscience, but if you'd like to watch it again, feel free. So, signs and symptoms of Huntington's disease. It's really a triad of things. There's going to be a movement disorder. The main movement disorder is chorea early on in the disorder, but that progresses into spasticity and rigidity. There's also a cognitive disorder and a psychiatric disorder that are part of Huntington's disease, but the amount of whether it's movement, cognitive, or psychiatric is going to vary from patient to patient. Usually the symptoms evolve slowly, and they are going to vary from person to person, even if the disorder was inherited from a family member and you've watched that family member, your symptoms might be very different. And the clinical course of Huntington's is shown in this slide, where on the far left-hand side of the slide are the signs and symptoms that I've just talked about, whether they're motor, cognitive, or psychiatric. And going over to the first column, the early clinical course is something called pre-manifest. That means there aren't really very many symptoms showing. Okay, there's a few, but very few. And as far as motor changes, you might notice, or the patient might notice, some mild gait changes. Okay, cognitive changes are going to be difficulty with complex thinking, and the psychiatric might be depression, aggression, and irritability. Okay, next stage in the clinical course of Huntington's disease is called the early stage. And motor symptoms that you might notice are a mild chorea, a dysdiadochokinesia or difficulty with rapid alternating movement. Patient might demonstrate increased DTRs, and they might have abnormal extraocular eye movements, so difficulty with smooth pursuit kind of activities. Early cognitive changes are going to be mild changes in executive functioning. And as far as psychiatric, the depression and irritability will continue as in the pre-manifest stage, but also some sadness might be apparent. Signs and symptoms for the middle stage. For motor, mild chorea develops into full-blown chorea, and you might have also dystonia, as well as rigidity and decreased motor coordination. And there's something called motor impersistence. And motor impersistence means that if the person is holding on to something, they just let go. Their ability to control muscle contraction is much reduced, and they might be able to grasp something, but then they're just going to release it. And this makes it really difficult for this patient population to use an assistive device, knowing that they might not be able to hold on to it. They may also demonstrate dysphagia and dysarthria, and definitely middle is characterized by some severe balance deficits. As far as cognitive is concerned, they're going to start to develop memory loss, anosognosia, which is a problem in this patient population because they have balance deficits, but they're not really aware of the fact that they have balance deficits, which makes them more apt to fall. And dual tasking is going to be hard as well. In the later stages of Huntington's, it sort of starts to look a little bit like Parkinson's for the motor problems, because you develop a bradykinesia and a rigidity, and the patient might also develop incontinence. Okay, this change is due to the fact that the entire striatum, meaning that both the caudate nucleus and the putamen, are becoming affected by Huntington's. Cognitively, they're going to have a global dementia, and psychiatrically, there's going to be a delirium. You should also be aware of the fact that this patient population is very prone to suicide.